All right, I have one for you. Along spectacular lines. Why are parallel lines so lonely? Because they never meet. Okay, how about this one? Why did the snake go to the baby toy store? Why did the snake go to the baby toy store? There is such a thing, apparently. If you're making a joke, you can make up stuff like that. He wanted to get a new rattle. All right. You guys, everyone had a good Halloween. So I was a skeleton. I don't know if you saw the picture. I pulled out a slide deck with a bunch of pictures of my kids and family, but I figured you wouldn't want to see those, so I just showed you the Halloween ones. What were you guys? Did you guys dress up? Yeah. Yeah? What were you? Ninja? My 6-year-old was a ninja last year. Don't worry, she's a trendsetter. Don't worry about it. No. Okay. Anything else? Somebody else dressed up? That's a little freaky. Okay. I like that. All right. You guys like the snow? Yes. Yes? No? Yes. So there's more tonight. Did you know that? Yeah, more tonight. Maybe another 1 to 3. Actually, I think from a school standpoint, the kids tomorrow might be a more challenging day for the buses. You know, so yeah. Those of you that have kids, pay attention to the 2-hour delay, or maybe it'll be a snow day. My kids are praying for the latter of the two. So it's amazing how quickly they get up and get dressed on a snow day for a 2-hour delay. It's like, do you want some breakfast? Nope. Right? And they are ready to go. And then on a school day, it's hard to let, remember your gloves and your hats, and your shoes, and comb your hair, and, it's snow days, man. Snow days are where it's at, flag. All right, so we've got endocrine to cover today. I did send out an updated slide deck kind of at the last minute. And so it's not a huge deal. I'll point out the slides that are changed because I think they'll flow better. That's why I did it this way. And so you may not have had time to print them out. But you can take notes and then maybe transfer those notes over to your new slide if you want to. But I had a note to myself from last semester. I like to make changes. I like to make improvements. And today I had a little time when I got into campus. And so I modified a couple of slides just because I thought from last semester it would flow better this way. Looking at the schedule, so next week, what's happening next week? We don't even have a lecture. There's not even an online lecture next week. You guys want one? I can make one up. Unless it's like how to build an upside down snowman. How to build an upside down snowman. My kids built an upside down snowman this morning. It's pretty cool. So there's nothing going on next week for this class. And so I had this debate. It was kind of this, quandary of, well, Veterans Day is on Wednesday, so we wouldn't actually have a face-to-face. So I could sort of, I think, not observe Veterans Day by having an online lecture, and you guys could watch it on Tuesday or Thursday, and then still have quizzes. But I just felt like it wasn't really in the spirit of taking the holiday and honoring our veterans. So Veterans Day, you don't have to come to class, and next week you actually don't even have any assignments for this class. But what might be advantageous is to study, because the following week we have an exam. Okay? So I thought it'd be kind of a double bonus in the sense of giving you a little extra time to study and not have brand new material for exam 2. So I'm very much expecting from all of you significantly higher scores on exam 2. Because we sort of have a week off prior to the exam. Okay? Plus, I don't know if you recall, but there was a week previous that we actually had 2 quizzes, 2 pre-quizzes, and 2 post-quizzes. And so we kind of made up that work already. We've already done it in preparation to take the next week off. Okay? All right, so that's the schedule. The withdrawal deadline is Friday. So if you think, it's usually not a whole lot of students in this class that applies to, but I do want to make sure that you're aware of the fact that deadline is approaching. And if you want to come see me, I have office hours this afternoon. We can look at your grade. We can kind of, we can even calculate exactly where you are, because I don't post midterm grades we're not required to. I think the university believes that by now that you should be capable of adding, subtracting, dividing, and multiplying. Okay? Even as biology majors, believe it or not. Okay? 1 animal plus 2 animals equals 3 animals. Okay? All right. So that's kind of our schedule. That's what's going on. We're going to dive into endocrine. We're rapidly approaching the closeout of the semester. Because I feel like once we get past the second exam, it feels like it just goes really fast. All right? But the second exam being after midterms, we're definitely more than 2/3 of the way through by that second exam. So today we're going to cover a little bit of review. Again, not much. But the review that we're going to cover is really going to be focused around what you talked about 202. And so I want to start off by characterizing and contrasting a couple of different terminologies. So the endocrine system itself is a network of glandular structures. And those structures are going to secrete a product, typically referred to as a hormone. And that hormone oftentimes is a protein, but not always. It can be a lipid-based material as well. But usually it's a protein. Those hormones get released, or those products get released into the bloodstream. And they circulate around, and they have broad effects to the organism. And so one of the advantages, if you recall back to 202, of the endocrine system is being able to utilize a small amount of chemical, a hormone, and causing a dramatic change across the systems of the organism. So the best example here would be puberty, right? Or as in Inside Out calls the button, puberty. Have you guys seen that movie? Okay, so it's that big red button that shows up at the end of the movie. So the puberty button started to show up at my house. It's kind of interesting. So, yeah, I know. Hang on tight, right? So in puberty, you've got a little bit of hormonal changes that are taking place, and you're causing dramatic alterations across the organism. It's not just to the reproductive system. Trust me, right? It happens. The brain is changing too, I'm pretty sure of it. Okay? So everything changes. Another one would be, have you ever been awoken in the middle of the night by like your dog barking, or you hear a loud noise, and you think that somebody's in the house? Well, in about 2 to 3 seconds, what happens? What's that? Your adrenaline response just kicks in, right? So you wake up, you're kind of groggy, like, what was that? And then like 2 to 3 seconds later, your heart feels like it's coming out of your chest. Okay? Well, that signal of adrenaline systemically is interacting with your nervous system, it's interacting with your heart, your respiratory system, it's interacting with the relative availability of glucose in the bloodstream, it's getting your muscles ready to contract, right? So this is a broad-based effect. Now, a little bit of change makes a broad-based effect, but what did I just say? How many seconds does it take? Maybe 2, okay? But it's definitely not milliseconds. Are you with me? It's definitely not as quick as if I threw my laser pointer to you and you reached out and grabbed it, right? Cat-like reflexes, okay? Or if you watch ESPN highlights, if any of you are in sports, okay? Whether it's, men or women doing their craft, some of these, top 10, the daily top 10, they're pretty impressive, right? Like, how in the world did you catch that ball? How did they save that goal, right? How did they identify where their feet were, right? The NFL players, the wide receivers that can catch the ball with like one hand and drag both feet as they're coming out of bounds, getting hit by like 270 pounds of muscle. and then being thrown into a cameraman, and then have this presence of mind to stand up and do a little dance, right? I'm like, wow, that's impressive, right? All of that's happening. So that's the nervous system. That's different than the hormonal or the endocrine system. So you've got two big systems that we've left the nervous system. Now we're moving into endocrine. And in 202, hopefully your instructor or your professor kind of compared and contrasted the two systems as one being a very fast system to respond, but it's local effects. The nervous system sends the signal to the muscle that's going to be contracting, or it sends it to the gland or the structure in the body that's going to be involved in that particular activity. And it does it within milliseconds. Whereas the endocrine system, it's broad-based, it goes all over, and it is relatively, it's slower to come online. The other example on the endocrine system is if you think about a mature female's 28-day cycle. Okay? There is something happening every day, and in 28 days now this environment is basically ready for the implantation of a fertilized egg. That's the whole point of that process. But it's not like the nervous system controls it, which is release the egg, implant, and in 2 seconds, bam, you got a baby. Right? It takes a 28-day cycle for that process to be ready for that. So that it's slower. And there are other changes, not just within the uterus of the female, as you remember back to 202. That 28-day cycle also involves some other changes in other parts of the body with the female as it's responding to the broad-based effect. Okay? So that's the first take-home message. Is the endocrine system is slower to act, but it's more broad in its effect. Other systems that I want to talk about, the paracrine process and an autocrine process. So if you have exocrine function versus endocrine, let's back up one step, exocrine versus endocrine. So compare and contrast the nervous system to the endocrine system. Now let's compare and contrast endocrine to exocrine. So endocrine system is going to release a protein or a substance into the bloodstream. The exocrine system is going to release a substance onto a surface, okay? Usually into a pathway that's going to lead to the outside environment, the external environment. So exocrine sweat, right? When you sweat, you're releasing out of ducts via an exocrine sweat gland excrement that's going to move onto the surface to the outside environment. When you think about the exocrine functionality of the digestive system, you have to remember back to 202 that the whole alimentary canal, where it starts with the mouth and ends with the anus, all of that lumen is considered outside the body. It's not part of the internal environment until you absorb it across that epithelium. It's epithelium. If you remember, epithelium is the terminology we use for the covering on the outermost surface, usually in contact with the outside environment, like the epithelium of the skin. So the epithelial lining of the GI tract is touching the outside environment. So if we look at exocrine as being releasing into the outside environment and putting it onto really a surface, that's another terminology difference that's unique that we need to characterize. Now we move into paracrine and autocrine. So endocrine, not being nervous system, endocrine not being exocrine, but endocrine being releasing it broad-based throughout the entire organism in the bloodstream, can also be contrasted with paracrine response and an autocrine response. Any volunteers on what these two terms mean, paracrine and autocrine?
In autocrine, the cell is able to secrete a mediator that stimulates itself.
Okay.
And in paracrine, the mediator stimulates neighboring cells.
Perfect. So paracrine, meaning nearby cells get stimulated by what that cell releases. Autocrine is the cell releases a compound and it stimulates that cell itself to do something. So an example of the autocrine we've already covered was that IL-2 co-stimulation in our immune system. You guys remember that for CD8 cells? So that IL-2 pathway was an example of an autocrine stimulation. All right. These are important because if you have an endocrine functionality taking place, you're releasing hormones. Let's say you're going to release insulin from the pancreatic beta cells. Well, you want to release the insulin, but you want all the cells, all the beta islet cells, to also release insulin. And so there's going to be a paracrine type of signaling within the pancreas to tell the whole pancreatic tissue to get with the program. Hey, we're doing this. Come on, let's go. Right? So there's a signal to all of the cells to do that. All right. If we classify our hormones, and I told you that they're mostly proteins, right? But not always. And so we've got the different classifications that are shown here. So we've got peptides, which are a segment of a protein. Smaller fragments, in fact, of that protein. They're secreted into the bloodstream, bless you. Some examples would be things like antidiuretic hormone, ADH, that comes from the posterior pituitary, and prolactin, which comes from the anterior pituitary. Those are both types of peptide hormones that we're going to look at. Now, a steroid, a second classification. This is an organic compound, right? And it usually includes the dietary fat known as cholesterol. So this was that other category I was telling you about. And so a lot of the sex hormones, the ones that are important during adolescence or puberty, are types of steroidal hormones. So estradiol and testosterone, right? Estradiol being the precursor to estrogen, and testosterone being the male sex hormone. Both of those are types of steroidal hormones. Now, we also have some other steroidals, like this hormone that's an anti-inflammatory hormone known as dexamethasone. So there's a lot of other ones too. We're just kind of pulling out a few. The monoamines, the family of monoamines. You know, again, these hormones, they're signalers. They're signaling agents, whether they're a peptide, a steroid, or a monoamine. So a monoamine example would be our adrenaline, like epinephrine. And epinephrine is another name for adrenaline, or norepinephrine, noradrenaline. These are types of monoamines. We also have some other examples like thyroid hormone or dopamine. These are both types of monoamines. Monoamines are manufactured or made from tyrosine. And then our last category that we're going to talk about are eicosanoids. Eicosanoids are pretty heavily involved in paracrine signaling, or signaling neighboring cells. And the eicosanoids are a 20-carbon compound that's derived from this precursor that we've talked about before, known as arachidonic acid. And so the arachidonic acid is the starting material, and it's used to manufacture the different families of eicosanoids. And do you guys remember some of those examples? Eicosanoids. Prostaglandins. Yep. Leukotrienes. Thromboxanes. Okay. What else? There's one more that's missing. What did we say? We said thromboxanes, leukotrienes, and prostaglandins. We're missing one last one. Prostacyclin. Okay? So all four of those had activity on the blood vessel. Do you guys remember that? They were vasoactive amines, is what we call them, from the family of eicosanoids. And very true to our definitions, they're being released in the bloodstream. They're having effect to neighboring cells to cause all of the cells of the blood vessel to either dilate or vasoconstrict, contract. Right? So we've seen some of these examples of hormones already throughout the semester. We're just kind of putting it into a new context today. Okay, now the other thing from 202 that we need, again, this is all part of this review, but from 202 that we need to remind ourselves is every hormone is going to have a receptor. And there's going to be a very specific specificity, meaning that one hormone binds to its subsequent receptor. And it's not supposed to bind to other things. If it does, we'll see where there might be some disease problems as we get non-specific binding that takes place. And then the other thing is there's a saturation point. You have only a certain number of receptors that will receive a certain number of hormones binding. And so one thing you can do is you can increase the production of hormone, but once you've saturated all the receptors, you're going to get you're not going to get an additional biological response. So you also need to upregulate the insertion of those specific receptors in the target tissue. It's another reason that using the hormonal pathway or the endocrine system takes more time than the nervous system. Because if you want to have a larger response to the same amount of hormone or more hormone, you have to upregulate, you have to manufacture, you have to take DNA, make RNA, right? Translate the RNA into a protein, and then the protein gets inserted into the surface of the cell, and that's a new transport receptor. And that binds to epinephrine or estradiol or testosterone on target tissue. So it takes time for the response to take place. So there's typically this saturation. So if you look at the way that we characterize this, upregulating and downregulating, we have a small stimulus, as what we said before, can lead to a great effect at the bottom because of the ability to ramp up. Well, if we want to upregulate the response, our hormone is represented by the little dots. The receptor is located here at the membrane. Well, we can actually increase the amount of receptors inserted in the membrane and therefore allow for a larger response to take place. Likewise, if we want to downregulate the response, we decrease the amount of receptors that are present at the surface, and now the response is less. We'll see this exact type of description show up in a couple of the new pictures that I put in today's lecture for diabetes. Diabetes mellitus type 1 and type 2, because I found some pictures as I was sniffing on the internet that nicely characterize this introductory slide, and I felt it did a nice job of that. Okay, a couple of other definitions: synergistic, antagonistic, and permissive. A synergistic response in the world of hormones means that it's greater than the sum. It's greater than the addition, right, of adding the two together. So what that means is if you have something like follicle stimulating hormone, FSH, and you add testosterone to it, you're going to output what we call adequate physiologically relevant sperm production in the male. But if you take one of those components away, you don't get appropriate levels of sperm production. What do you mean by appropriate? Well, enough to cause fertilization to take place. Okay? So if you have an infertile male, it could be either an FSH issue or it could be a testosterone issue. Okay? And just because one is upregulated and the other one isn't a problem, it may not be enough to equal the output. So the synergism is follicle stimulating with testosterone leads to appropriate physiologically normal sperm production in males. An antagonistic effect of hormones could be where they have opposing actions. So the example here would be insulin is a molecule that lowers blood glucose levels. It causes the uptake of glucose into the cell. And glucagon does just the opposite. It's antagonistic. It causes the cell to dump glucose into the bloodstream. So it increases blood glucose levels. So those would be antagonistic. Then the last one, permissive. Permissive is one hormone enhances the response of the second hormone. So we picked on males in the first one, so we'll pick on females here. Estrogen functions to stimulate the upregulation of progesterone receptors in target tissue. So this is how estrogen and progesterone work together. So during the menstrual cycle, if you remember back to 202, on that 28-day cycle, you saw two peaks that you would follow with two hormone activities. One was estrogen and the second one was progesterone. And so estrogen, what it does is it helps to enable or get the target tissue, in this case the uterine lining, ready to respond to progesterone. So when it fluctuates up, it inserts higher, or it increases the insertion of a higher amount of progesterone receptors in that target tissue so that progesterone can have its effects. That's permissive. One helps to allow or facilitate the second one to take place. Okay? So, I'm not sure how this was presented in 202. And so I want to take a little time to talk about it here. We call this in endocrinology, we call these different axes of effect. And so what you can see is everything kind of starts up at the top of the slide with the hypothalamus. Right? This is the structure that's just below the thalamus, which is this relay center in the middle of the brain. And the thalamus sends signals to the pituitary gland. This saccular-looking structure is the pituitary gland, and the front of it is known as the anterior pituitary, and the back of it is known as the posterior pituitary. Now this slide is very AP focused, anterior pituitary focused, and it's talking about all the different, or it's demonstrating all of the different compounds that are being released by the hypothalamus and having effect on the pituitary gland, and then moving out down their respective axis to the target tissue. So if we just take one, for example, when we look at the thyroid, we've got the hypothalamus manufacturing thyroid-releasing hormone. That has activity on the anterior pituitary to cause it to release the thyroid-stimulating hormone, which its target tissue is the thyroid, and then the thyroid is going to release T3 and T4. Make sense? So that's one particular axis. Now the reason I like to describe it this way is because, even if you haven't had it 202, is if something is wrong with a patient, this is where our class comes in, it may, let's say, for example, the patient is exhibiting problems that look like a thyroid problem. How are you confident in knowing that it's a thyroid problem? Is that the only option? No. Let's say it's making too much thyroid hormone. Does that mean that the thyroid is overactive and the thyroid is the problem? Maybe not necessarily. That's exactly the answer I'm looking for. Not necessarily. Some of you are like, I don't get it. Isn't it what makes it? Well, yeah. What if it's just fine, but it's being told by the pituitary gland to make more thyroid than necessary, thyroid hormone than necessary, because it's releasing too much TSH? Well, what happens if the anterior pituitary is fine, but it's being told by the hypothalamus because the hypothalamus is releasing too much thyroid-releasing hormone, which then causes the anterior pituitary to release thyroid-stimulating, which then causes the thyroid to manufacture too much thyroid hormone. So that's following this particular axis. So in endocrinology, this is how a lot of the diagnosis takes place. Is you look at a clinical system and you have to think about the axis, and then you might do certain blood tests, certain scans to determine, okay, this isn't a problem, and that's not a problem. So with blood work and with imaging, you can kind of pinpoint where the actual issue is. Make sense? So that's why the axis representation is actually helpful, because it actually shows you that it's not as straightforward as we might want to think. It's actually a little bit more complicated to figure out exactly where the problem is. All right, keeping that in mind, we've got this close relationship between the hypothalamus and the pituitary gland. This one actually shows the two lobes and labels them. It shows the anterior up front, and it shows the posterior towards the back. And it even describes at least the products that are being made. So the hypothalamus is making all these releasing hormones, right, that comes out of the hypothalamus. Gonadotropin-releasing hormone, thyrotropin-releasing hormone, corticotropin-releasing hormone, prolactin-releasing hormone, prolactin-inhibiting hormone, growth hormone-releasing hormone, and somatostatin. Right? This is all straight from 202. Now, the anterior lobe is what is going to release different types of hormones that have activity in the different respective axis locations of the body. So if you recall, we're here, and now you've got follicle-stimulating hormone, luteinizing hormone, thyroid stimulating, which is what we just talked about, adrenocorticotropic hormone, prolactin, and growth hormone. Okay, so we've got our two main products. Now, the hypothalamus itself is obviously part of the brain. The anterior pituitary as well, it's referred to as the adenohypophysis, and it's a glandular anterior lobe of that pituitary gland. Now, also part of the brain, the posterior pituitary is actually considered not to be really part of the endocrine system. The neurohypophysis, this one is actually not really a gland. Okay, this one is, or not in the endocrine system. So the hypothalamus and the anterior pituitary are part of this endocrine process that's releasing hormones into the bloodstream. So you have neural tissue that releases hormones into the bloodstream. In the posterior pituitary, this structure this one's actually just composed of neurons. But it actually has two main products that it manufactures that eventually make it into the bloodstream from the axoplasmic flow. So the neurohypophysis, the posterior pituitary, is really a collection of axons. It's not really a gland. Whereas we consider the hypothalamus and we consider the anterior pituitary glandular structures. So the posterior pituitary releases two products. Number one is called oxytocin. I don't know if you remember that from 202. Oxytocin does what? What's that? Makes you feel good? Well, so there is a sort of a euphoric feeling. It's released with females for lactation and nursing, and then also for uterine contractions. So maybe not as euphoric with the uterine contraction thing, okay? But with the lactation and the milk letdown, women have reported that there is sort of this bonding event that takes place between the infant and the mom because of that nursing event. And the evolutionary thought process, or the significance here is, to wire into females some positive reward for caring for their infant, right? And so the brain has some elements of a euphoric feeling after milk letdown because of the role of oxytocin, okay? And guys are scratching their head like, oh, yeah, because we don't have it, so you don't get it, okay? They didn't give it to us, okay? Vasopressin is the other one. We're going to talk more about vasopressin today. Vasopressin also has another term called antidiuretic hormone. And the role of antidiuretic hormone is exactly that. It's to conserve water. It has action on the kidneys. It causes arterial contraction. And it causes the urine to be more concentrated, and you pull water out. You reabsorb more water so that you raise blood pressure. So you'll release antidiuretic hormone when your blood volume is starting to become compromised. Okay? Meaning you release antidiuretic hormone when you say, I don't want to urinate and lose too much water. I want it to be very concentrated so I preserve the amount of water I have. And then that's when your urine looks really, really yellow, dark yellow, right? And ADH is working because it's keeping the fluid in your bloodstream. And so we'll talk about ADH more actively. The anterior pituitary gland has this portal system that connects it to the hypothalamus. And it's a venule network that actually connects it. And so you've got your axonal bodies in the hypothalamus. They release these releasing hormones into the venule network that then moves into the anterior pituitary. And now the anterior pituitary releases into the vasculature its specific stimulating hormones. And we talked about the posterior pituitary being more of neuronal tract axons. So the axons in the hypothalamus are like what you see in the posterior pituitary. Okay? All of this is Crash Course 202. Now, I want to talk a little bit about some of the system disorders. As we organize a lecture, we're going to go in order of the different organs that we want to talk about, kind of from top down. So the first ones that are up are going to be the pituitary gland, because we're up in the brain. Now, categorically speaking, we typically are going to see with endocrinology either everything is homeostatically normal, or you have too much being released, or you have too little. Okay, you probably saw that from the quiz, the pre-quiz, right? And you'll see that on the post-quiz, and you'll see that on the exam. Is I'm trying to help you understand. So if I turn something up too much, what happens? If I turn it down too low, then what happens? And so the impaired synthesis could be either hyper, which is too much, or hypo, which is too little. Both can be disease states. This statement of ectopic foci, what that means is there could be a location within that gland that is the focal problem. That's the ectopic center. That means a unique location within the organ. It's not necessarily saying that the whole organ is problematic. So, for example, thyroid issues are actually fairly common. In fact, my daughter has a thyroid, slight thyroid abnormality. And I'll talk a little bit more about that as the lecture moves on. And so the concern when you talk about the thyroid, is it the whole thyroid, or are there just little spots, right, on either the right side or the left side? And so that's the first, well, the first decision-making process is it the thyroid, or is it something up in the brain, like we just talked about? Then once you know it's the thyroid, then the question is, where in the thyroid is it? Is it on the right? Is it on the left? Is it the whole thing? Is it just little specific lesions? So the ectopic foci are when there's small little lesions, not the whole organ. Make sense? Hypo is where it's too low. We've already said that. Now, we've got abnormal interactions that will happen between the hormone and the target organs now, if you're too much or too low. And we've got an abnormal target organ response. So if the target organ is the thyroid, and you tell it to make too much, then the thyroid slowly over time will enlarge, right? If you tell it to make too little, right, then the thyroid could actually, in some cases, enlarge or shrink, but the target organ is going to have an abnormal response based upon your abnormal signal that's going to the target organ. Now, how do we get some of these lesions? Well, we left cancer in this unit. And so so I don't know if you've noticed, but I try to group the segments in the units together so they make some logical sense, right? So we have the nervous system in with endocrine, and we also have cancer in with endocrine, because a lot of times these abnormal ectopic foci, or we have impaired synthesis that's taking place in a particular gland or an organ, it's because there's actually an adenoma or a lesion that's located in that spot. And if that lesion is benign and it behaves and looks like the tissue that it's coming from, then you might see overactivity of hormone production. You with me? So think about it. If you have a benign lesion on the thyroid and it's acting like thyroid tissue as it grows, now it's going to become hyperactive. Okay? Same thing in the brain with the hypothalamus or the posterior or anterior pituitary. Now, if we're looking at the hypothalamus, we can go back and look at our different hormones. So GHRH, gonadotropin, or growth hormone releasing hormone. GHRH. The GHIH, or somatostatin, this is inhibiting hormone. Growth hormone inhibiting hormone. So the hypothalamus has the ability to influence growth hormone production, has the ability to influence prolactin production. PRF is prolactin factor, and it's upregulating it. PIF is prolactin inhibiting factor, otherwise known as dopamine, so you can go up or down with prolactin. GnRH, gonadotropin releasing hormone, or thyrotropin releasing hormone, TRH, or CRH, corticotropin releasing hormone. So the hypothalamus has this ability to influence all these downstream organs? Well, one of the downstream organs is the pituitary, right? The main one is the pituitary. So the question that I'm posing here is, considering this anatomical architecture that we've just described, if you look up here in the brain and you see that up top is the hypothalamus, so here's our hypothalamic neurosecretory cells that are releasing them into, this is the adrenal hypophysis, this is the anterior pituitary, known as the adrenal hypophysis in the front. Well, if you have an adenoma and you're going to have a issue associated with the pituitary as it relates to any of the downstream activities of the target tissue that we talked about, which pituitary gland is it going to be targeting? Anterior or posterior? Anterior, right? So if it's going to be influencing target tissues like breast tissue or the adrenal glands, or it's going to be influencing the thyroid, all of this is going to be an adenoma that would be located in the anterior pituitary. So we have a adenoma, a cancerous mass, or a precancerous mass if it's benign. It can either be functional, silent, or hormone negative. Well, what does that mean? Well, functional is pretty, I think, straightforward. Functional means that it's producing hormone that has clinical effects. And if it's a benign adenoma, what's the likelihood that it's making hormone from that particular tissue? Very, very high, right? Because remember, the definition of benign adenomas is that it's got well-defined borders, it looks like the surrounding tissue, it's very well differentiated, meaning it looks like anterior pituitary tissue, and it's growing, and so it's manufacturing more hormone as it grows. It could be silent, though. It could be producing hormone, but that hormone, something's wrong with it. So it doesn't have clinical effects. So silent adenoma is it makes hormone, but that hormone doesn't have any activity. And then the third one, hormone negative, is it doesn't make any hormone at all. Okay, so we've got kind of three different scenarios. Now, the manifestations, and we're in this category of looking at a lesion on the pituitary. So the manifestations of the pituitary gland with the lesion is, because of its location near the optic chiasm, you could have optic chiasm impingement. That means you could have vision being affected. Even though the occipital lobe's in the back, but because the optic chiasm for the two eyes come right underneath where the pituitary gland sits, if that enlarges, it could put pressure on the optic chiasm, and that could cause vision problems. Cranial nerve impingement. Well, depending upon which direction the adenoma grows, it can put pressure on a variety of different cranial nerves. So if you have hypersecretion at the level of the anterior pituitary, the effect is going to depend on what type of hormone is being hypersecreted. So let's pretend that the hormone that's being hypersecreted is TSH, thyroid stimulating hormone, in our first example. Well, it's going to have effects on the thyroid and cause the thyroid to produce more thyroid hormone. Make sense? Well, if it's going to have an effect on the family of factors that are going to influence other target tissues, like, for example, growth hormone, right? If it's going to manufacture additional growth hormone, well, then that individual may actually have problems with outrageous growth during adolescent years or childhood. So the effect, the manifestation of hypersecretion depends on what hormone actually is overproduced. Hyposecretion, undersecretion. The tumor itself can put pressure on the surrounding tissue. And so as the tumor grows, even if it's making hormone, if it gets too big, it can start putting pressure on the surrounding tissue and start quenching the nearby tissue for manufacturing healthy hormone. So it might be functional, it might be releasing active hormone, but it may be growing now and starting to create a hyposecretion response because it's putting pressure on nearby tissue. So is it possible that a patient can have hypersecretion first and then hyposecretion as the tumor enlarges? Yes. Okay. All right. If we look at our first example that I was alluding to on growth hormone, and I've been kind of talking about thyroid and now growth hormone. We've got our first clinical scenario, and we'll get to thyroid here in a minute. So this is gigantism and acromegaly. So growth hormone, if it's overproduced, it typically goes hand in hand with insulin-like growth factor. So insulin-like growth factor is the primary mediator of the effects of growth hormone. Because what insulin-like growth factor does is it stimulates the body to get ready to respond to growth hormone. So insulin-like growth factor is manufactured by the liver. So growth hormone has activity on the liver to manufacture more insulin-like growth factor. And then the insulin-like growth factor goes to muscles and bones and says, get ready to insert more, respond to insulin in a greater effect so that you can bring in more energy into your cell so that you can actually grow. Make sense? So insulin-like growth factor is manufactured by the liver. Growth hormone tells the liver to make more of it. It circulates around ahead of time, kind of like a Paul Revere, warning the target tissues, you're about to be asked to do more stuff. So what you should do is insert more, manufacture more insulin receptors, so when the body makes insulin, you respond to it at the muscle and the bone level, bring in more sugar, so that you can actually work harder, because that's what the body's going to want you to do. So growth hormone and insulin-like growth factor work in concert with each other. So in these patients, they have, when they're younger, they're releasing more growth hormone than normal. They have higher levels of insulin-like growth factor as well. And so they are hyperinsulinemic. They manufacture more insulin than you or I, and that binds to their muscle and their bone, and it brings in more energy into those tissues, and it allows for the muscle and the bone to grow much more aggressively. So when these individuals have growth hormone levels that are too high during adolescence or in their pediatric years, then we get into what we call gigantism. And so these individuals are really, really big. Okay? And once the growth plates close, the growth hormone, if it's still being released in high amounts, now the long bones don't have any way to respond. And so now you start getting some deformations that take place. And that's where the disease moves into what we call acromegaly. Okay, so acromegaly is the adult version of gigantism. So let's take a peek at these pictures, and I'm going to give you a little bit of explanation as to what's happening. So in this top picture, this is an individual in the upper image where you can see this patient is exhibiting some clinical symptoms like sort of a more prominent forehead. The forehead is what we call frontal bossing. This frontal bossing from the side is, you can see how the ridge of the eyes is more dense than the skull cap as it comes back. Excuse me. Patient has, where's my voice? Patient has very prominent cheekbones. So frontal bossing, prominent cheekbones. And what's happening is, over time, the growth hormone and the insulin-like growth factor is still being released, and those target tissues are saying we're going to continue to grow more bone in this individual because we're getting the signal to do so. So this patient has an enlarged jaw, very prominent lines in the face, overlying skin is thickened, and this patient is exhibiting signs of acromegaly. Now the bottom patient is a female, and this individual that was shown up here had growth hormone abnormalities that took place as an adult and as an adult only. As a child and then into the adulthood. So this individual was very large as well. This individual is a very classic picture of a young woman who was not developing gigantism or did not have gigantism issues younger in life, but later as an adult had started developing excess growth hormone production, and you can see sort of the masculinization of this young woman that's taken place, and you can see how aggressive the hands look. You can't see them in these pictures, but you can kind of appreciate that some of these same features that I described in this gentleman up top is being found in this woman, where there's prominent forehead, prominent lines on the face, very discreet cheekbones and chin. A lot of similar features between these two individuals. And this patient down here didn't have gigantism, only developed it during adulthood. Okay? So this type 2 diabetes that's on this slide, I want to talk about this for a second because we're gonna get there. But what happens here is this growth hormone pathway, this excess growth hormone that's being released, a lot of times what it does is it causes type 2 diabetes-like symptoms. And the reason for it is that the peripheral glucose uptake loses its sensitivity to insulin. And what that does over time, because there's so much insulin around because of the patient being hyper insulinemic as well, they lose the sensitivity to insulin, and so the target tissue stops responding to it. So what happens is then they make more because the target tissue is not responding. And this is exactly what happens with type 2 diabetes. One of the pathways of type 2 diabetes is you lose the sensitivity to insulin, so you make more. In a lot of type 2 diabetic patients, we have too much insulin in the bloodstream. And what's happened is the target tissues have become desensitized to it. And so if they become desensitized to it, you make more. And this is one of the classic symptoms of type 2 diabetes. So we'll get to the symptoms and what happens with type 2 diabetes after the break. But just think back when we get there to these patients that are wrestling with acromegaly, that they have some of the same problems. Okay, I'm going to do the slides again because I want to show you an image. This is an MRI that is looking at a sagittal view of the skull. Okay, so the patient is looking to your left. You can see the cerebellum down here. You can see the brainstem right here. You can nicely appreciate the corpus callosum right here in the scan. It's actually a really, really clear image. And this is a prolactinoma. This is actually the most commonly hormonally active tumor that we'll find in the anterior pituitary. Even more common than the result of growth hormone, gigantism or acromegaly. And so in this one, you can actually appreciate we've pseudo-colored this optic nerve. And here is this prolactinoma that's highlighted in red. And so you kind of appreciate how it might put pressure and impinge on the optic chiasm, right? Well, if this thing is active, hormonally active, it leads to high serum levels of prolactin, and we get some interesting side effects that takes place. In women, we get what's called galacturia, and this is the spontaneous flow of milk that's not associated with childbirthing or nursing. Okay, so all you ladies that are in the room right now, is as if milk started to flow, and you know you're not pregnant, and you don't have kids, okay? So that would be a clear sign that you're probably going to go make an appointment to see your doctor. Amenorrhea. Amenorrhea is the absence of a menstrual cycle. Now, so here's one of the challenges here is, in a lot of very active women, the menstrual cycle may become very irregular, and it may actually go away altogether. And so this one is not as clean of a signal in a woman. But if a woman is very, very regular with her menstrual cycle, and then all of a sudden they stop, that might be an indication that there might be a prolactinoma taking place. In males, okay, in males we've got oligospermia, reduced libido, and erectile dysfunction, because you have more feminizing type of things happening with the excess of prolactin being produced. So oligospermia is semen that's produced because seminal fluid is manufactured by organs down in the pelvic region. It has nothing to do with the brain. But the semen itself has an absence or a very low sperm count. That's oligospermia. Reduced libido. Libido is sex drive. So the male result is the sex drive drops. And that coincides with, erectile dysfunction. Don't necessarily need that if there's no sex drive. Okay? So these would be the symptoms for males and females. Now, what happens if we have hypopituitarism versus hyper? Those ones that we just got done talking about with the classic, the most common hormonally active being prolactinoma. But we also talked about pituitary gigantism and acromegaly. Now, those were all too much. Now this is an example of too low. Well, what could cause too low? Instead of, we talked about an adenoma or a tumor causing too much. Too low, we said already first, too low could be the tumor itself grows and starts putting pressure. So you want to add that to the list. That could actually flip it from being too much to being too low, hypopituitarism. And that would be this etc. category that's listed down here. So that's what I usually talk about. Okay? So working back up to the top is infarction. So if a patient had a stroke, right, and there was a region of the brain that was compromised and infarcted and died off, it was necrotic, it would be what type of necrosis? What's that? Liquefactive. Nicely done. See how it worked in a cumulative type of question right there? Yeah, you like that? Okay. You don't like it, but you're glad that I demonstrated. Okay. So, liquefactive necrosis, right? And it targets the anterior pituitary gland, and now it shuts off production. That's one example. Traumatic brain injury. Trauma causes damage to that location. Brain infections that cause issues associated with the anterior pituitary. Surgical damage. So this is an interesting one. It's not quite as common, but it does happen. If a patient is hyperpituitary, it is a neurosurgeon's prerogative to come in and surgically take out that portion of the brain. Now, if it's benign, they probably don't want to go in. But if it looks like it's growing, they may not have a choice. And so they'll go into the brain, take it out, and if they take out too much, now all of a sudden the patient is hypo when they recover. Okay, so that's the surgical example. The etc. example could be if, what we just described previously, if the adenoma grows, it was hyper because it's active, and now it's putting pressure on the surrounding tissues and shutting them off from being able to manufacture appropriate levels of hormone. Now it switches over to hypo. The last one on the list, Sheehan syndrome. This one's kind of weird, okay? But Sheehan syndrome only affects females, right? It's named after an individual, not like it's a she disease or something like that, okay? Sheehan was the name of, I believe it was a Japanese physician that sort of classified it. We'll talk about another one, another Japanese physician's name of Hashimoto disease, but that's coming later. So Sheehan syndrome is in females postpartum, after delivery. There's oftentimes a pituitary infarction that can take place, or they're at risk of. And the reason for it is the pituitary gland itself actually enlarges during pregnancy. So, interesting fact, gentlemen. Women's brains physically get bigger when they're pregnant. Okay? So if you think they're smart now, beware. Okay? They actually have larger brains during pregnancy. And it's because of all the hormones that are being needed from the anterior pituitary. So as their pituitary gland enlarges during pregnancy, and then immediately after birth, when there's a loss of blood, there could be a loss of blood during, I don't know if you've seen this, folks, but there is some blood that takes place when a baby's delivered. That loss of blood volume can cause an immediate drop in blood pressure to the pituitary gland and cause a local infarction just in the side of the pituitary. So Sheehan syndrome is due to vasospasms of those arteries of the anterior pituitary collapse during postpartum hemorrhage. And so it's more rare. It's not every pregnancy. Okay, so I'm never having kids. I'm not trying to scare you ladies. But that's why they're monitoring blood loss so carefully. It's for a lot of reasons. But that's one of them. Is the brain is very sensitive because now the pituitary gland is actually enlarged during your pregnancy, and it's calling for more blood. So it's actually a little bit more susceptible to an infarct, and that would be considered a Sheehan syndrome. Okay. The last one that we're going to talk about in this section before the break, and I do this intentionally because we talk about two different types of diabetes. And this is the less common. But if I talk about it together, it's in the lecture, it seems like it's more easy to mix them up. So diabetes insipidus, and of course, in contrast, diabetes mellitus, which is the one you're more familiar hearing about. So diabetes insipidus is a disease that targets the posterior pituitary. We've been talking about the anterior pituitary. Now we're going to talk about the posterior. So the posterior pituitary, I write that on the slide, it releases antidiuretic hormone, ADH, right? Also known as vasopressin. And remind me, what does vasopressin do? Retains water. It prevents water loss, right? So if you're hypo-ADH secretion, then you're at risk of developing a condition known as diabetes insipidus. So the term diabetes in Latin is the word for siphon, siphoning. And insipidus means without taste. So you siphon out taste is what that literally translates to. You with me? So diabetes insipidus, the Latin translation is siphoning out taste, meaning that you're watering down your urine. Like, who's tasting the urine? Okay? Well, they used to smell it, actually. Okay? And it'll become more obvious when we talk about the other type of diabetes later in the lecture. Okay? But diabetes insipidus literally translates as siphoning out the taste because you create extremely dilute urine. And so the symptoms are going to be polyuria, excessive urination. That's the first P. Get it? Okay, all right. That was a totally forced laugh, but that's okay. I appreciate it. Okay. If I read it off a cue card, would you guys like it better? All right. It's because it's my kids. You're laughing for it's for the kids. It's for the kids. So polyuria, polydipsia, which is excessive thirst. Polydipsia, that's the second P. Polyuria, polydipsia, hypernatremia. Hypernatremia, that's an elevated level of sodium in the blood. Okay? Those are our three main symptoms in diabetes insipidus. Now, the causes of diabetes insipidus could be one of two things. It could be neurogenic or nephrogenic. Neuro meaning it affects the neurons, right, of the brain, which is the posterior pituitary. So that's the most common, neurogenic diabetes insipidus. And in this situation, there's a lack of vasopressin being manufactured by the pituitary gland. That's neurogenic. And remember, it's neurotissue, it's axons, so that should make sense. Nephrogenic, where do you think that problem lies? Nephrogenic. It lies in the kidneys. It's often associated with end-stage renal failure. So end-stage renal failure, nephrogenic diabetes insipidus, is the inability of the kidney to respond normally to the vasopressin. And so the vasopressin is being released by the pituitary gland. It hits the kidney, but the kidney is in such bad shape, it doesn't listen, and it just allows the water to be excreted. Okay, so two different types. Pretty clear? Questions on that? All right, let's take a break. I'll put up more pics of the cam because I put them together, and then we'll come back in about 5 minutes.